Morning.
Just hitting 9. I'm just getting our, we're now going to be streaming this on YouTube live. I think should be up and running.
Brad, I don't know if anyone else had the same problem, but I couldn't open the agenda.
Okay, I'm not sure. I
kept giving me some weird message, so but I'm sure I can follow along.
We'll go over the agenda pretty early on, so hopefully it will be pretty clear what we're going to be covering. Nothing crazy. It's not no surprises on the agenda for today. Just waiting to see if Kate is joining before we get started. And we'll get going here just in a second, even if she's not. Well, it's 9:02, so why don't we get started, just given we have 2 hours and a lot to kind of go over. So welcome everybody. Just as a reminder, this is being recorded, or it's being streamed live on YouTube for public and will be viewable on video there. Morning, Kate.
Good morning. How are you? Good morning, everyone.
So Sandy, hopefully this helps with the lack of being able to see the agenda before, so my apologies for that. So
no problem.
Just going to do a brief review of our last meeting and some timeline, as well as feedback on the revised goals. And then we're going to spend most of our time getting report outs from our subgroups and then hearing and having discussion on that. So we will be spending a lot of time in that this morning. So, just brief review. I think after our last meeting, we made some updates to our stated kind of goals, and then identified the need for 3 kind of subgroups, including finance, quality, and principles. And so we'll be hearing about those today. We kind of nailed down some of our, I think, general decision points that we'll go over shortly. And then Kate, update on executive order. I know there's still some stuff pending there if you want to provide a 1-second overview or one-liner.
Well, good morning, everyone. We're so privileged to have all of you join us again. And I just want to thank so much, especially those of you who soldiered on in the work groups in the interval between the meetings. It's greatly appreciated. With respect to the executive order, I just want to confirm what I said the last time. As originally as issued by Governor Lamont, the executive order would have required a report out at the end of January of this year. And for all kinds of reasons associated with the pandemic, as you all are aware, there were delays in Commissioner Gifford convening this body. Long story short, I think our department and the governor's office both mutually compelled to extend the time frame for the executive order. It's in process. We haven't seen reissuance occur yet, but please be assured that we have agreement around submission of the report at a later juncture point, which will give us appropriate amount of time to make the recommendations. So thanks, Brad, for being able to just confirm that.
No problem. Thank you. So just kind of to ground us again in kind of a lot of the health equity framework that we're kind of using, thinking through this a bit, just kind of reminding us. So thinking about improving on the left-hand side, improving the health and well-being of people, on the right, improving the health and well-being of places, and acknowledging that that there's unequal access to a lot of social determinants of health due to various structural factors, including racism, access to education, et cetera. And so just keeping this in mind as we're going through our processes. And so I've been using this for every one of our meetings. Let's see, so timeline, just a update. So we're kind of in the middle, getting closer to the end of things. And last time we, again, decided to start focusing on subgroups. We've kind of made some decision points, which we'll review, and we're still having one meeting per month with our subgroups meeting kind of as needed, which I think has really helped propel this forward. So thanks for everyone's engagement and leadership there. And then we'll be finalizing recommendations by July. So we have our May and June meeting remaining after this one. So just here's our refined goals after our last meeting. We took some feedback and modified them. We'll just run through them because we can still continue to do that. And we may end up taking this and starting to think about combining it with recommendations as we move forward here. So identification of a core set of currently available equity-informed quality and cost data points that will be reported out publicly on a routine basis. Identification of means of measuring program impact on population health, social determinants of health, and other areas that need further time to implement. Benchmarking our performance on the core measure set and also aspirational measures as that becomes feasible over time and against performance of other states. Visualization of data in accessible, plain language, electronic dashboard format that enables a broad view of measures for purpose of program accountability and continuous quality assessment improvement. Drill down capacity for purposes of routinizing access to raw de-identified data, scheduled refreshes of the data, and push alerts to queue interested parties to updates. So we don't necessarily need to go spend a lot of time on this today, but if there is further feedback, I think there's opportunities to, like I said, refine this further, consider how we might incorporate this into taking some of these goals into recommendations as we move forward. And these are just some of the discussions and kind of things that seems that we've kind of finalized. So we just want to confirm that with everyone. So based on our discussion last time for audience, we kind of said focus on general public, but including but not specifically targeted to policymakers, consumers, and researchers. So, you know, a general, kind of a very general perspective here. And I think that was kind of the takeaway we discussed, whether there should be a focus on some subgroups, but that would seem to be the consensus. Transparency vehicle platform, a electronic dashboard web platform with visualized data and repository for other reports, data sets. And then we talked a lot about data stratification and access, and this is kind of a very much drilled down one-liner here, but we went through the specific things that we'd be hoping to stratify by. So key indicators including geography, race, ethnicity, disability, multiple others, would drill down other capacity to permit researchers to download raw de-identified data. We talked about comparisons briefly. I think everyone kind of agreed we should do it across states, regions, nation, payers, providers, and time. And then obviously that can be stratified further. So let me pause here, just get feedback, make sure we're capturing this correctly based off of kind of the discussion from last time. These can get incorporated into our kind of formalized recommendations. So anyone, if just for purposes of discussion, if anyone wants to raise their hand, I'll try to help keep an eye on that. So we're in Zoom, I'm just reminding myself. So raising of the hand is a feature that is easy to do. Okay. So just give everyone a moment. So again, any comments, feedback on these kind of discussions from last time, kind of finalize these kind of our initial recommendations on these points. All right, so I'm not seeing any comments, so I think generally some consensus. If there are further thoughts or feedback or something, you wake up in the middle of the night and you're like, oh, I should have said that, please feel free to email. We welcome that feedback. We'll continue to use this process to refine our kind of decision points for formal recommendations moving forward. So with that, we're actually going to jump into the meat of our discussion today. And again, big thanks to all of the subgroups, so quality measures, principles, and finance. This is kind of the format we'll take. So about a 5 to 10 minute brief report out from each of the subgroups. Thanks for everyone for helping put together some brief slides so that we'll have something to visualize as we talk through this. And then after each of the brief report outs, we'll actually spend time discussing. I'll keep an eye on time. Just so that we make sure we finish and have opportunity to get through each section today. So with that, I think we can jump in. I think Susan was able to join, and I think Susanna is also on, just thinking about our quality measures report out. So I believe, Susanna, you might be taking this first slide just to kind of report out from the quality subgroup. You're on mute. No problem.
Okay, how's that?
Perfect.
Okay.
Thank you.
Yeah, so I will see if I can do our team justice and make lots of space for people to add in. What you see here is not yet a full list of measures, just to be clear, but really trying to think through a framework for thinking about measures that would capture all of the areas that are important to Medicaid, that are important to this advisory group. So there's some example measures, and I want to give a huge amount of credit to Susan, who really created this beautiful thing that you're looking at and populated with some ideas. So I'm just going to walk you through the way that we tried to capture the kinds of measures that we thought would be useful to have be shown as a part of the dashboard we're creating, and what we mean by some of the columns. And then I'll pause and hear from folks. Obviously, the next step would begin to fill this in more thoroughly. So we just have a few examples here to give you a feel. So, so what you see is 6 rows. The first is the population health, well-being, and primary prevention. So this is a row trying to capture a lot of the things that contribute to people's health, as opposed to the quality of the care they're getting once they're already sick. So, and for each of these rows, what you'll see is that we have columns that represent different kinds of measures. So we're thinking about outcome measures. What are things that sort of represent population health or well-being, sort of the end goal? We have process measures. What are the things that we might measure that we broadly, we as a community, we as providers, we as do that lead to better outcomes in this area? And then for each of these, we also have a column thinking about member experience and satisfaction. This is a placeholder for places where we might be able to actually hear directly from beneficiaries in each of these areas. Again, I personally don't anticipate that we're going to have necessarily lots of measures for every single one of these squares, but this is meant as a framework that helps us sort of think through priority areas for measurement and begin to categorize measures that we think are either already available or might be feasible in the very near term or might be aspirational in the longer term. What you'll see in this first row is that we included primary prevention. I'll just note this is one of the areas of discussion. You obviously could put primary prevention in other rows. We talked about ways of combining differently. So we welcome feedback from this group about the ways that we categorize. There's no perfect solution, but just to name again, to give you a feel, I won't go through every row in such detail, but this row represents things like kindergarten readiness or 3rd grade readiness, but it also represents, prevalence of diabetes, and are we managing pre-diabetes and diabetes well, and it could represent life expectancy. And then when you look in the process measures, what are some of the things that we might measure that contribute to this? Screening for falls, wellness visits, and where might we get some data that represents members' experience and satisfaction with our ability to do this, to promote these kinds of things. The second row is more typical clinical quality measures. You can imagine a lot of the Medicaid and core measures would fall here. These are measures of both outcomes and processes related to the provision of primary care, management of acute diseases, management of chronic diseases. The third row is its own row related to social determinants of health. Obviously, social determinants of health can contribute to all of the other rows, but we wanted a place where we might capture how well we are screening for social determinants of health, helping to help beneficiaries manage social determinants of health, improving, food insecurity. So that's what this row is meant to represent. The fourth row is a place where we might capture information that's more related to the Medicaid population itself. Who's enrolled, what does churn look like, access. Kate showed early on some interesting data about how good the network is for patients. So that kind of information we think is also really important and could be represented by measures we put in this row. The fifth row is meant to capture the fact that there are populations that deserve is a funny word. There are populations that we want to make sure their care gets represented. And so rather than trying to be sure we weaved it in all of these other rows, we thought it made sense to just bring that forth as its own row so that we're sure as a committee that we will think about measures to put. So for example, I don't even know what all of these abbreviations mean, I'm embarrassed to say, but we've talked about folks in the long-term services and supports. You might put pediatrics here. That's been a group that's been brought up a lot by this group. The jailed population, right? So just making sure that we're thinking about outcomes and processes of care for special populations. I'm going to pause here in particular because I feel like I'm not representing these initials well, and I want to give folks a chance to remind me what some of these examples are.
I think you've done a great job, Susanna, with these. The alphabet soup can be difficult for all of us. So, a couple of them, and again, I'll ask other folks also to chime in because, again, I'm a little new to some of this, but Money Follows the Person, the CHEST initiative, looking at homeless populations, the various waivers. So, obviously, these are, wanted to, again, it's not exclusive. This is just some of our preliminary thinking and just really to prime the pump for discussion for today.
Great.
And
I'm going to say, oh, go ahead, please.
Oh, I'm so sorry, Susanna. And Susan, thank you so much. I just wanted to wrap around briefly to say this conversation is really illustrative of something I think we do have to be conscious of, as that we do rely on these shorthand descriptors, and we have to think about annotating in a way that will illuminate, what's the premises, especially as it, reflects our reform agenda. In some cases, this work is beyond the bounds of the Medicaid state plan. So Money Follows the Person is an example of a federal demonstration grant that is essentially reform-minded and is testing interventions that some of which we have taken up and incorporated within the umbrella of Medicaid. But some of those things feel relevant and meaningful to me in terms of like how we're facilitating the use of the data ultimately. CHEST is an example of an initiative that includes Medicaid services, supportive housing services, but also braids with housing vouchers from the Department of Housing. So that is an example of cross-departmental piece that directly attaches to some of the social determinant pieces that might be featured in the first row. So there's I think a relational aspect of this also. But again, I commend this just for further discussion of the group. I think that's for me a set of interesting questions around how that's depicted.
Great, thank you, Kate. I'll say just one other word because I don't want to leave it out, and then I'm going to stop so that we can hear from Susan and hear from folks. The last row obviously relates to cost, which we spent less time in our quality subgroup, but is a part of this executive order. And then I just want to make sure we speak to this nice light blue line that separates the rows from the columns, which is just representing what Brad laid out earlier, which is this intent that as we fill this grid with the highest priority measures, we are intending to make sure that we have the ability in any of these spaces to look at them by demographic and geographic variables. And I'm going to stop there. Susan, first, I just want to see if you want to add things on this or go to your next slide, or whether you guys think we should open this up.
From my perspective, I think you did a great job, and I don't think you've missed anything, but I do want to give space for folks to comment if they would like.
That's fine. Yeah, we could do that. I was going to say we could kind of, if you wanted to, Susan, go over the next slide and then come back for overall comment. That's okay.
Sure, glad to do that. So, you know, first, I also just want to add my voice to thanking the various subgroups and particularly the folks on quality. We've had just really robust, really dynamic, really substantive conversations. So I really appreciate folks, you know, sharing and helping us to fill this out, and obviously look forward to the conversation today to continue this. So as indicated, we were just trying to identify those major categories of particular, of categorizing, certain ways of categorizing these measures at a core level. And then obviously, as Susanna noted, also, how do we potentially unpack those in terms of outcomes and process measures and sentiment analysis. But obviously there's greater detail that we need to get into, particularly once we've identified what those specific measures are going to be. You know, and some of this is also going to require us to get some definitional clarity. So we had put access under the enrollment and churn, but again, depending on how we define that, it really could go under different things. You know, when I think about the matrix, I actually really, every time I say that, I think of the movie. When I think about this matrix, I think about it almost like a Rubik's Cube, that it's more three-dimensional, and that it's on an axis and you have these units. And so you really could kind of rotate it in different ways. And so, you know, for example, as we talked about, the social determinants of health really could cut across. So you really think about this and again, in more of a, you know, 3 dimensions rather than 2 dimensions. And so I think obviously some of this we're going to need to kind of think through, and how's the best way that we can represent some of this information, again, that does really seem to kind of have a vertical and a horizontal kind of an axis. You know, clearly we also want to make sure that we are representing early detection. So again, where does that fit, and really what does that mean? We, you know, very much as we talked about that line where we want to ensure that we are disaggregating these data by key demographics and geography. We also want to think about that actual analytic representation related to equality. So when the principal subgroup speaks, I think you're going to see that equity is top of mind and really at the center of this work. And so we also want to think about how analytically do we present this in the best way. So thinking about disproportionality and disparity and other ratios and indexes that really allow us to do good comparisons and make sure that we're getting equitable outcomes. And we also need to attend to some of the meta pieces of this. So those meta documents about what's the source of the data, where is it coming from, so that we have integrity. We also can have, you know, replication, repeatability of any of the measures. So that's just some of the homework pieces that we're going to need to do. Again, once we get to the brass tacks of the particular measures and metrics, we really need to be thinking about the availability of those data. You know, what's some of the low-hanging fruit, what's the information that potentially exists in what format, and then getting into the feasibility of that. And some of that may be, if we're looking at collecting data across multiple systems and we have to do matching and other transformations, sometimes the complexity of that will mean that we need to kind of figure out, is this something that we need to put more under some of our innovative or longer term measures, because it will take a little bit more time and effort in order to kind of really augment those data to make those transformations and bring that level of detail that we need in order to present it publicly. So I think this is where we'll probably need to have some discussions about kind of a high-low, you know, kind of high-low in terms of availability and feasibility, you know, type of a ranking to figure out what's going to make some sense, and then try to order it. And I think that gets us, you know, to the to this piece related to kind of the development and staging piece of this. So really thinking about the phases of this. And so, you know, what can we present out more quickly than others? You know, what's our kind of medium and longer term time frame in terms of continuing to mature the dashboard and the data sets potentially. So, you know, starting to kind of rough some of that and sketch out, you know, what's our general plan in order to stand something up as expeditiously as possible, but also attending to how do we continue to do this? How do we make sure that we are populating this with timely data, and, you know, and how we're continually addressing that user experience and that user interface piece of it. So I'll leave that there and
Thank you.
lateral back to you, Brad.
Thank you, Susan. Thank you, Susanna. So just want to open it up for discussion now. If folks don't mind trying to raise your hand, we'll try to keep an eye on the participant list, but I think feedback would be helpful. I'm happy to go back to the other slide as well, if that helps just for visualization purposes. I see, Vicki, your hand's up, so go ahead and jump in.
Thanks, Brad. Good morning, everybody. It's nice to see all of you. I'm sorry I couldn't make the last meetings. Obviously a lot of work went into this, so that's much appreciated. I guess I just have a question about how would we, clearly there are measures in the Medicaid measure set that will go beyond what other payers might use in clinical quality measures, but I'm just trying to see where the alignment is with the EO5 Quality Council. Because we have a whole quality council that I know Susanna's on. I don't know if it's Brad or Kate, somebody from DSS actually is on that council as well. So just trying to make sure we maintain that minimal, the alignment on the minimal like quality set that cuts across payers, also attends to some of the issues around equity, while we have special measures, I'm sure, on the Medicaid side. So I just trying to figure out how that melds into this work. I don't know who should respond to that.
I was just going to.
Yeah, Vicki, I just want to say I'm so grateful that you would surface this. We have not specifically articulated that in the principles that will be presented by Karen and Grace later, but I think we will want to commend that for discussion, because we definitely subscribe to the shared intent around alignment to the extent that we can. Obviously, there will be, and you acknowledge there'll be pieces of one above that Medicaid is going to have the capability to articulate. But I think I'm sure that the folks involved in the principals group and also the measure selection group would concur that we agree on that. So well stated.
Thank you. Just trying to minimize some of the burden on providers as well, cut across multiple payers. Thank you.
I'm on mute now.
Yeah.
Let's see if I can help you unmute or not. Oh, it looks like you're unmuted.
Yeah. Did you call me?
Yeah, sorry if I did. My apologies. I called on you. I'm apparently not doing a great job yet. So.
No worries. I'd like to underscore what a helpful framework this is, and ask a question to either Susanna or Susan about measures of efficiency. It seems that this appears to be kind of oriented around things that people get, and the utility of those things, which I think is very useful. But in the framework of thinking about cost, there is a kind of a separate orientation about kind of the things that people get that they don't need to get. And one way to think about that is those measures are more difficult to kind of get our hands around, but one way to think about that is kind of understanding variation across geographic regions. Is that part of this? Is that kind of outside of the scope of what we're thinking about with kind of version 1.0 here, or?
Susan or Suzanne, I would let you guys weigh in if you want to speak for the subgroup.
I'll start, and obviously I welcome other folks, thought about it. I don't necessarily know if it's outside of 1.0. I think we need to obviously consider it. I think it's important and a great point. I think as we're starting to unpack what's available in the feasibility, we can certainly look at that and see, kind of where within this phasing does it make sense. I come from, kind of the olden kind of the RBA kind of framework as well. And so I do see that as, being under that kind of in that outcome processy, kind of nether region to really kind of think about, how some of those pieces, fit in. So I don't think it is any way outside of this. It's just really figuring out where's the best place to nest this. And I think the availability of the data is going to drive some of that.
I mean, the only thing I'll add is I just think it's such a good point because, when we look at cost, what Kate showed us early on is that if you just look purely at a sort of per member per month, our state does really well, but hidden in there is under and over service. And if you're thinking about sort of the quality, if we just drive towards spending as little as possible while that has some benefit, we don't know if we're doing the right thing for patients. And I think that's what you're trying to get at. So can we start to understand better when we are doing things that cost money and do not help people live healthier lives? And that's really what we want to get at. And, just looking at costs by outcomes moves in that direction, but it doesn't really help. And there's not, as you well know, there's not enough measures that do that well. But I think it's a really good point because it's not represented well here. And I think maybe we just put it on that punch list to come back to because it's an important area of opportunity for us to figure out, what are the things we're not doing enough of that the state of Connecticut could do more, but then where are the places where we can save and improve lives. So, and I think you're right that it doesn't quite get captured by just having these in different rows. I don't have a good answer, but I think I like that we have sort of a punch list of things we need to come back and think about because I think it's really important.
And then I know you had your hand up, Suzanne, so I don't know if you wanted to add anything else.
Oh, I just wanted to say one thing to Vicki's fantastic point, which is, can we think about alignment from every moment? The one place where we might just purposely, I don't mean purposely not align, but where the Quality Council is thinking about measures for plans, and this group is thinking, I think, about sort of how the state is doing it as a whole for a population. So there may be things that don't feel appropriate for assessing a plan and holding them accountable for that might be really important for transparency, for where Medicaid's trying to drive as a state. So I think we should be thinking about alignment all along, and we may just want to asterisk things that we feel like make sense at a state level and not at a plan level, so that we aren't losing the opportunity to illuminate some things that it might be really important to illuminate in this piece of work as opposed to the Quality Council.
And I'll just make one comment is that I think even in as we're thinking about across payers within states, that we have to be what are the things that we have that we can measure across, and if people have if we can agree upon things at the Quality Council and there's a core measure set that we can use for at least some of those things, then that's a great opportunity to help as part of that measurement. So definitely agree. And I think maybe I didn't include it today, but I think in the last meeting I'd put the Quality Council core measures on there as well, because that would be a meaningful opportunity for measurement across. Thanks for my indulgence of jumping in here. Grace, I think you're up next.
Yeah, I'm unmuted. Isn't that great? Congratulate me. I think Susanna basically said this better than I will. So I just want to kind of thank you, Susanna, for articulating it and maybe reinforce the weird and fine line balance we really have to adhere to. The value of, making sure a population that has such severe inequities in social determinants of many kinds, including healthcare access. And then are there places where the healthcare system, by lack of coordination, perhaps, and data system efficiencies, may miss that things get either repeated or in some way get done that shouldn't be done, which we want to be very careful about. But, and I'm glad it did get brought up, but with this, I've been part of national committees that talk about this a lot, the Choosing Wisely Coalition in Connecticut, and yet it's a broad issue that when we bring it to the Medicaid population, it clearly requires a certain care and thinking about not missing the inequity part and the lack of service part that's, prime concern. Along with that, in terms of efficiency and cost, the idea that a large investment, it seems like a large cost, that down the road saves money, but is also adheres to the values of helping people be healthier. We want to, I think, adhere to those values consistently so that we make sure that we're doing what we need to do for people. So and I think to Susan's point about this being three-dimensional, I think it's almost a web because of how all these things interrelate. So that, just to reinforce what's been said earlier and appreciate it all. Thank you.
Thank you, Grace. I have, I think, Kate and then Sandy.
I just want to thank everyone so much for this extremely thoughtful discussion. Chima for raising it, Susanna for building on this, and Grace for those points that you just made. I see this as an essential lens through which we must examine everything that we're doing here. I think Susanna really hit on some pieces in terms of, what are the core values of the program? And I just wanted to say a couple of things. The reason that we grounded this entire discussion in that perhaps overwhelming inventory of our reform strategies and then the available sources of data that describe quality for us was really intended to underscore that in Connecticut Medicaid, we've deliberately taken the approach with grateful thanks and acknowledgement of successive administrations who prioritize this aspect of permissive eligibility standards, arguably the most expansive in the country, with the exception of perhaps Washington, D.C. The breadth of our preventive coverage, medical, behavioral health, and dental, the adjunct services, the deliberate layered investments in prevention that the administrations have successively made, and also our self-insured structure with it, which is itself designed to efficiently support operations of the program, by contrast to the historical norm of the high administrative cost of capitated managed care. These elements are deliberately intended to promote not only the breadth of the access and the breadth of services that is needed by our membership, but also to avoid what I think has been too unfortunately historical norm in many Medicaid programs of taking a kind of crass cutting type of approach. When budget exigencies surface, lopping off services, truncating eligibility parameters. Our view of how we achieve efficiency, and there are many descriptors of that, I see that as about optimizing services to members, both from the standpoint of adequate services, but avoidance, as Chima was pointing to, of duplication and unnecessary services, the waste component. Not only that piece, but how we promote the efficient use of taxpayer dollars, which is abundantly captured in Deputy Commissioner Gilbert's detail. And I know we're going to be quickly getting to that piece later in this discussion. But for me, that's an essential kind of framing piece of how we look at this. And I think we are at a point of maturity with our approach that enables us not only to look longitudinally at the impact on the measures approximating outcomes at this point, but also start responsibly and morally examining the waste aspect that Chima pointed to. I think our concern typically has been around underservice and access, but I think having solidified some of the features that afford those things, and with an absolute caveat that the disparities must continue to be surfaced vigilantly, I do think we are poised to talk about some of those things. And I would just say briefly, there's myriad potential examples. I've heard from the UConn Center on Aging repeatedly around urine testing of nursing home residents, a very common practice with very low utility. So that's an example of something that might categorically be described as having low value. Another example is we are paying far more for customized wheelchairs than many states. So that's a pricing issue that may relate to the kind of features of the landscape with providers and their level of influence and control because of limited cadre of them. Anyway, I don't want to freak the discussion with too many examples, but I think we're very interested in those descriptors as they are now, it's now feasible for us to examine those in context of having established a program that can be accountable in those ways that I described. And I'd really like us to keep discussing this. So again, thank you so much.
Thank you, Kate. Sandy?
Yeah, hi, good morning. I'd like to address two pieces of this. First, what Kate and Grace were talking about. with, you know, under-service and not getting things to patients is clearly a problem, but over is also a problem. And from sort of a practitioner's point of view, you know, the choosing wisely, I think, is excellent and has not been taken up maybe as much as we'd like to by as many primary care people. And you know, repeating things causes delays, and a lot of it is communication. So there really is, when this happens, it really, the patient is really being hurt, and causes various delays in care. That was sort of my first point. And secondly, in the special populations group, I'm not sure where it goes, but I think we need to have a particular look at the perinatal period. So the pregnant woman through pregnancy and postpartum and the newborn period, maybe up to 9 months to a year of age, is a special population that has particular needs. And within the pediatric population, the children with special health care needs. That's a large number of kids who really do have particular needs. And again, there is both not enough done for some of them and too much done for some of them, both of which have a negative impact on the ultimate outcomes.
Thank you, Sandy. Karen?
I was just gonna chime in and on the cost issue, and as we're looking at how these rows really do interact with each other, I think one of the things to consider also is that increased costs on preventive care, particularly primary prevention or social determinants of health, those savings may be captured in other sectors or in other state agencies. And so those cost metrics also, I would hope, would reflect cross-sector savings as well, instead of focusing solely on Medicaid, just like the well-being and social determinants and some of these other measures capture things that are more focused on whole people and on population level care. I think we could take the same consideration with cost.
Thank you, Karen. Suzanne, I see your hand up, and just FYI, we're approaching kind of our time limit for discussion in this area. Suzanne's not hand up. Okay, so we have about 20 seconds left on my timer. What kind of the next steps will be subgroup taking back comments and feedback. If there are other ones, feel free to send them to myself, Susan, Susanna, and we can bring those back to our next kind of subgroup meeting. So we will make sure to take these thoughts and this great feedback and input. Oops, sorry, it's my timer, and bring that to the subgroup, and then feed that back, and then bring this back again to the larger group. So let's keep moving along to our principles. So I didn't skip over. No, perfect. Okay, I think Karen, you're going to take the initial lead, and Karen Grace are going to present out on this. I'll pass the baton over to you guys.
Okay, thanks, Brad. So this was a meetings of Kate, Susan, Brad, Karen, and me, and you know, I think what's really helpful is to have had the first part of this meeting first, because hopefully you'll all see some resonance in what we've come up with for principles. And you know, what we're suggesting is that we go through both of 2 slides together and then open it up, because this is kind of introductory, you know, contextual, and the actual principles that are drafted are on the next slide. So I'll just run you through the first one, and then Karen will take the next one. So a statement of intent we developed, the data that is featured in the Husky Health Data Dashboard, and I am actually blocked by the, I can't move the each of us being shown, so I'm missing the end of each of these words. So I'm just gonna guess at what they are. I can't control what I'm looking at. Anyway, but the data shown is used to illuminate the experiences and outcomes of Medicaid members with an emphasis on achieving equity for all served. Then the next one is member informed, selected with a lens that safeguards against reinforcing preconceptions and stereotypes, and presented in a clear and comprehensible manner in formats that accommodate access but all wish to use it. So for this purpose, the term equity means that everyone has a fair and just opportunity to reach their optimal health regardless of race, ethnicity, disability, gender identity, sexual orientation, socioeconomic status. Further, the Transparency Board wishes to ensure that the Department of Social Services applies these principles across the life cycle of the data, and that'll be elucidated more in the next slide that DSS collects and manages, but the little cycle to the right gives you a sense of what that life cycle is as well. And I think it would be useful just to take a good look at that and then go on to the principles that are on the next slide. Karen?
Great, thanks. Yeah, this was I think it was a nice conversation, and I think in the interest of time, I'm going to just read through these, and then if folks have questions about context or why they were included, any of those of us who were in the subgroup can answer those. So the principles that we settled on were the process through which DSS collects, reviews, sunsets, and replaces data points and measures for the purposes of quality improvement must be person-centered, member-informed, inclusive, and transparent. The second one is whenever possible, data points should be standardized across the enterprise to reduce the reporting burden on Husky Health members and providers. Third, selection, use, and publication of data points and measures should safeguard the privacy and dignity of Husky Health members. The next one is within the above parameters and where feasible, data points and measures should routinely be disaggregated and publicly reported by race, ethnicity, age, and other demographic factors. When data is adjusted to account for age, risk, or other factors, both adjusted and unadjusted measures will be reported. Selection and use of measures should anticipate and mitigate unintended consequences, including but not limited to a failure to comprehensively identify intended beneficiaries of an intervention, such as may occur through an algorithm, underservice of members, or adverse impact on providers that serve a high incidence of Husky Health members. To avoid misperception and stigma, DSS should always use best efforts to identify and report out on a baseline or reference group and provide contextual detail in reporting out disparities. So that's what we've got.
Thank you, Karen and Grace. So looking for feedback, discussion on these principles if they meet the mark, or if we need to further refine them.
It's a great list. Thank you.
This is Ann. I also agree. I think it's well written, and you know, the idea that, you know, kind of that cyclical approach, which of course goes along with quality improvement. So, you know, with equity in the middle. So I like it.
And I'll just loop back to that first slide just so folks can see this as well for any further feedback here.
While people are thinking and framing their thoughts, I just want to say I'm so indebted to the folks who were participating in this group, Karen and Grace in particular. We had the most interesting and far-ranging conversation around equity matters that really transcended the principles piece. And it's so exciting to be able to talk in this vein. And I think the bottom line is I want to encourage everyone to press us at the department. We want to be progressive with this, and we want to shift culture in our orientation around this. And I think Karen and Grace were raising matters that expand our horizons in that. So I do want to just say that that's a distinct interest on our part. Everyone in the department is involved. Please do, urge us on in that respect. I don't know if you agree, Bat. I know you had some thoughts around the discussion too.
No, I agree. And I think it's helpful to kind of think, think about how we're incorporating this into our transparency board work and where we place this, and also including how we think about even presenting the data to a degree. And there's discussion about placing, if you have a transparency vehicle or a dashboard, do you place something at the top to help make sure that people have some semblance of understanding of kind of where this is coming from, what approaches to it, and that then there could be a deeper dive if folks wanted to go deeper, but just to at least give individuals some context for how this data is being presented and why. And I think that was a really helpful conversation that we had as part of this. Not seeing any other hands raised, which I think means, again, I also credit Grace and Karen for making this happen. And I think we can still further maybe review this internally as well and bring this back to the group. But this may put us well ahead of schedule, which is great. I'm sure people won't mind that in any way. So with that, I think, Gemma, go ahead.
Hey, Brad, can I ask a quick question? So it strikes me that disparities or equity could either be viewed as something that happens kind of between groups or across groups. Sorry, between settings or across settings. That is kind of understanding whether we are seeing the same outcomes for individuals within the same hospital, or if we are seeing outcomes differ in part because people are going to different qualities of hospitals. What level are we willing to kind of publicly report this data to try to get not just at the extent to which we are seeing inequities in the system, but also kind of understanding the drivers?
Good question. And I'm not sure if we'll have that identified. And I'm sure there'll actually be, you identified some tensions that may exist, even within these principles of publicly reporting information, but also, just going down to this bullet, adverse impact on providers that serve a high incidence might be a tension with some of that publicly reporting information. And so I think you raise a really important point that there may be some tension with how some of this information is displayed, and whether that's within groups or across, hospitals or something like that. That will need to be really thoughtfully important. That'll be something that's important as we kind of look at the data and figure out, does this make sense to present, or is this actually not? And I think this is maybe back to what Karen said, and Grace, is that this is where it's like you need some public accountability for how these decisions are made, if that makes sense, because there are pros and cons of doing it, and it's not, at least from my perspective, it's not always going to be clear what the best thing to do is. And I don't know if the others from the group feel differently or have other thoughts.
I'll just wrap around very briefly and say, Chima, thank you for raising that. We had no historical precedent until the implementation of our PCMH Plus initiative, our value-based primary care initiative, for provider identified data reporting. That was our kind of precedent-setting exercise in that, to identify the advanced practices by name. And I think it's had a lot of utility. So I will say generally the commissioner favors by name identification, I think, with those provisos that we just talked about. So again, I think we really invite members of the group to help us apply that principle around not wanting to disfavor providers that serve a high incidence of Medicaid members, and blow that out in discussion as much as we can.
Well, if I can just jump in and add that part of the discussion was also, we don't want the data to be used in payment models in a way that disadvantages safety net providers, but also don't want data to be adjusted and only provided in an adjusted way that doesn't allow for clear quality comparisons. So I think there was a discussion about how do we find that balance, and I think there's no perfect answer, and would love to hear more about other people's ideas about how to do that.
And Jim, I don't know if you have any thoughts. I'd be curious. I mean, I think you have a lot of expertise in this. And
Yeah, so I think Karen and Kate and others are right in kind of identifying this natural tension, both in kind of two ways. One, it's not the case that everything that we know has to be kind of publicly reported to the community, or rather to the public, in part because there are challenges associated with doing so. But yeah, there's also this second issue of trying to figure out uh, how much of outcomes are associated with kind of the mix of groups that you see, and how much of outcomes are associated with the kind of production or the things that are happening in the care system. And it's one that we, I think, as a kind of academic and policy community, haven't quite gotten right yet. The challenge with waiting till we get the perfect system, however, is that it's not entirely clear that these measures have teeth, right? And that they help us move forward. So I don't. Karen's correct in suggesting that I'm not sure that we quite understand what the right middle ground is, but my hope is that there is one.
Thank you, Bonnie.
Following up on the point about sharing provider level data, and I think the really good example of PCMH where you have a program that wraps around it. I think that to Chima's point, that when we share provider level data, especially, that we'll need to make sure we're building in even more training for groups that might be able to make use of the data, especially provider groups, so that they understand the data in advance that's being possibly shared about their practice, and how they can put initiatives into place to have the ideal outcomes.
Thank you, Bonnie. Susanna.
I'm just realizing that this all raises a good question about assumptions about sort of drill down on some of these measures, because to the extent that this is a state report card, one can imagine that it wouldn't include provider level. Now, will it be used to then launch initiatives that would look at provider level data? I hope so, right? I mean, that would be the ideal way that it would be used per your circle to highlight areas where we need to improve and drive that improvement. But anyway, just noting that I think it is really important when you start to show performance of providers to think about how you handle case mix and service mix and things like that. But that may be that may not be the first level for this particular dashboard. And so that, I think it's an important thing for us to think about, is sort of how much the public view of some of these things should or shouldn't drill down to provider groups. I don't know if there are answers.
Thank you, Susanna. Kate?
Yeah, and great discussion, and just a couple things. I do want to say there is a lot of this work that goes on, particularly under the leadership of CHMCT. A non-exclusive example is the PCMH. That's the foundational person-centered medical home initiative that prefaced PCMH Plus. CHN does a practice profile for each and every participant of that pay for performance initiative. And they not only annotate that very specifically to set context, but they engage in direct interviews with the practices on an annual basis. So it's a very dynamic process, around level setting, the comparisons, and then also, wrapping around with practice supports. And I think at any point there's interest in hearing CHN talk a little bit more about some of those examples, I think that would be great. I also hear Susanna's point, and also Karen's around the premise of the data, acuity is just one example, but I think that's something we've had to very carefully negotiate on in context of PCMH and PCMH plus. Each member of Medicaid in Connecticut is risk stratified on the basis of use of a Johns Hopkins tool care analyzer. So that, there's definitely a lot of thought around that type of methodology. And again, I'm conscious of Karen's point around absolute performance rather than, as compared to the, qualifiers that can modify those types of things like acuity. But I do just want to end by saying that the dashboard is going to be one extremely important means through which the department broadcasts and utilizes data, particularly to inform continuous quality improvement and new reform initiatives, but it is not exclusive, so that the practice profiles will just be one example of an adjunct piece that is specifically intended, to Bonnie's point, to engage with providers and set context for performance ongoing. I'm a little worried that we might have lost Brad. Is anyone able to discern him? I no longer see him. I'm wondering if he had a connection issue. In the meantime, I do see Grace and then followed by Susanna both have their hands up. So Grace, may I turn to you?
Yeah, so thank you, Kate. I think that the issue of cross-provider, cross-practice, cross-institution, be it an institution that's an individual primary care clinic like an FQHC, or a larger institution, or a conglomerate, emerging system of hospitals, brings up issues of practice for an individual based on their own quality standards and unique factors about their individual self. But then the constraints of some of what might be going on within their institution. And I'm guessing that CHNCT takes that kind of thing into account. Sometimes in institutions in crisis, and very dedicated people are trying to do the right thing by patients, but they're dealing with major administrative hurdles and constraints. So in some way, it's important that, as Karen has said often, the provider shouldn't be faulted for dealing with a patient population that's burdened with problems, but if they're dedicated to that population in an institution that isn't adequately serving their needs as providers, how does, to be sure that that gets elucidated. So as providers, they're not sort of called out when they're actually doing something heroic in very difficult circumstances.
Hey, everybody.
We're delighted to see you back on. We saw you wink out. Unfortunately, I know we all have the travails of the technology, but back to you.
Yeah, unfortunately, I'm on my my phone at the moment. It seems my internet in my house just went out, so I don't think I can present, unfortunately, the slides at the moment. But I think someone's hand might be raised, and I will do my best. Sandy, I think your hand's up, so go ahead.
I think it's me. No, I couldn't agree more with what Grace just said. When you're looking at things sort of globally, it's one thing, but when you get down to actually what's happening within a particular practice or even with a particular provider, there are lots of things that they have absolutely no control over. And also I think something that we don't want to discourage is practices not being completely Medicaid. So in other words, having practices with all kinds of payers in it. And so we, obviously you're not going to change how you're treating patients by what kind of insurance they have. So whatever we do is basically for everybody. So we want to continue. I think it's really valuable to see patients from all different payers to make a diverse practice. So, but thank you for that, Grace. That point, that was really very important.
Okay, I don't see any other hands up, and Bonnie, I saw your kind offer to potentially share your screen. I don't know if you're actually able to or not, but if you have it and you want to, feel free to try to do that.
I think I just need permission from the host.
Can do that or not, because I am now not logged on as the host, unfortunately. So we may have some slight technical issues. I don't know if
Fatmata, if you could give me the permission, you're the host for Zoom. If not, I'll speak to them.
well,
If that would help.
I don't think we have any other comments at the moment. And let me see what I can do here. Why don't we move on to the finance subgroup, and at least we can start with kind of going over them, and I will, in the meantime, try to get myself back so I can present. I think I might be able to get a hotspot going here, and we might be back in business. So if you just want to at least go through that first slide, and then we'll make sure we have it displayed here in just a moment so everyone can see.
Sure, and Meg, jump into at any time. And I think for our finance subgroup, one thing that's terrific is we're almost a subgroup of the other two subgroups. So I think that the themes that were discussed and the frameworks really apply to the finance subgroup, and in some ways, our slides are sort of less visual, but I think just sort of a piece of that puzzle that was already presented. For our subgroup, we also really have a wealth of well-established, well-validated measures that also are already transparently presented through the MAPOC structure. So in part, our subgroup focused first on what would be the measures that we would want to make sure were transparently shared as part of this project. And those include existing financial metrics that are annual now, including category of service breakdown, per member per month cost trends overall and by program, that was mentioned earlier in this call, state share of Medicaid expenses, and also Medicaid share of the total Connecticut state budget, and the administrative expense ratio. As we had the discussion before about sort of over and underspending at the member level, we are all in a strong agreement that we want the administrative expense ratio to be as low as possible. Those measures already noted actually are available through the posted MAPOC presentation as an example from this past January. And also we called out several measures that would be good to consider that are quarterly, including again, per member per month overall and by Husky program, expenditures overall, and enrollment overall and by program. And I think, again, many of these were sort of mentioned above in both the quality subgroup and having a row or rows for costs, and also sort of these all fit within the principles discussed by the transparency subgroup as well.
And Bonnie, you probably able to see that I was able to share.
Yes, yes.
So hopefully we're back in business now and everyone can see this.
And I think this slide really gets at items that we likely people may want to discuss further. And again, Meg, jump in too. We worked on these together in the group. Here, I think there are additional significant considerations, some of which echo the elements discussed already, but some of them I think are specific to finance metrics. Again, because we have such well-established, well-validated measures that are existing, it's really critical that as these get shared through this DSS initiative that we're recognizing that we're going to have sort of this emphasis on one truth that we all share and all can draw from. Again, many of the measures discussed, they are available already, but sometimes they might be, especially for the general public, more difficult to find the spot on their website, or they might be in different places, and we want to make it sort of one easy place for folks to come to. And where possible, we really want to link financial metrics to program and policy objectives. And again, as mentioned, the metrics established by the quality group. We want the financial metrics to fit within this larger context. And also, we want to include or make sure we're accounting for medical inflation and health system cost trends for comparison purposes, and a place where there's opportunity to sort of enhance what we have, really try to investigate the availability of other state comparisons where they're applicable. And also that really would require us to, again, further make sure we're helping any viewer of this information understand differences in context, understand when we have sort of close comparisons, how still is Connecticut unique? And I think many of the layered and longitudinal investments that Kate mentioned before are really critical. Where we are fortunate in Connecticut, we have a very long track record of success and being really progressive. And so there might be places where benchmarks are really applicable, but there still might be nuances that we need to highlight for folks how we're different and why then our metrics might, comparisons might be somewhat different. The next one is one of my favorites. We need to make sure we have a data dictionary and, again, an explanatory context for measures. This one is so helpful, I think, across the board, across all the work that we're doing, whether we are the person who is sort of helping pull the data, helping do the analysis, or we're someone much newer to one of the metrics someone might be looking at. It's always helpful to try to have reminders, breakdowns, and make it really easy for someone to understand what are they looking at, and also sort of what are they not looking at. And so one example that we talked about in our group is sort of that reminder to folks that we're looking often in the finance area at paid claims by date of payment. That's just sort of one quick reminder that I think is simple, but it also gets at something that Chima said before, which is the information that we do have is when our most vulnerable members are touching the system. And so we have the information based on services used that that resulted in a payment. And so often it might mean, let's say that what we don't have is information on folks with maybe a similar condition, but they never sought care. And so they're off our radar. It's just sort of one example of how the data dictionary also helps us explain and understand and then communicate with each other about what we're looking at. And I think the last bullet is also really critical and loops back to the other subgroups very much also, is that we need to focus on the story behind the data, the key takeaways. And to Susanna's point before too, sometimes if we're able to allow people to drill down in something, we still want to possibly have a framework for the dashboard that doesn't lose sight of the bigger picture or some of the key takeaways. And to make sure that we're adding narratives or other kinds of context, some of it could be the data dictionary, that really explains the human impact, the member level impact of what it is we're trying to look at.
That was great, Bonnie. Thank you. We didn't practice this, and she did an excellent job at doing it all. But just to add a couple things, the telling the story piece. One of that is also, if you're going to be connecting these to some of the outcome data or other things that are being reported, what was the intent of an increase in expenditure? Was the intent, the intent was to bring in more primary care providers. Then you looked, was that out? Did it bring their intended outcome? And what was the quality of that outcome? And indicators associated with that outcome. And that helps when we look back at the data, I think, as well as looking forward at the data, so that people who are new to the data can understand why there might be increases in expenditures or understand why certain things were done as far as the finances. And then the other piece, and I think we've brought that, this has been brought up in MAPOC quite a bit when these reports have been brought up, is, you know, this is very Medicaid focused, this data, and we look at per member per month costs and the increases in costs and the increases in spend. Well, how does that relate to the rest of the medical community and the medical inflation in general? And I think maybe there'll be some cross references to some of the other initiatives that are going on in the state with regard to this, but you know, it makes it less insular. It allows us another data point for us to look at and look at the comparisons, particularly from the provider perspective. And then as people are drilling into the data behind the dashboard, they'll also be able to make some comparisons and do their own benchmarking. And so these data points might be helpful.
Thank you, Meg. Any comments from the rest of the board, thoughts? Please feel free to raise hands and actually only go, there's one more, I think. And actually, Mike, I don't know if you want to add anything. I know Mike Gilbert has been very helpful in kind of helping the subgroup work through all of this. So I want to make sure to offer him an opportunity to weigh in as well.
Thank you, Brad, and thank you, Bonnie and Mag. I think you did a wonderful job with the presentation. I wouldn't have too much to, well, just a few things to add to that based upon the conversation today. And I know that Bonnie and Mag have hit upon this, but I think this was meant to be sort of it's public facing information, right? It's vetted, it's sort of tried and true, but we certainly are looking to evolve our framework and open to feedback, but this would be something that we could put out very quickly and I think provide some meaningful information. But to the other points that were raised in the discussion today, we are always looking for ways to enhance the lens in this area. And I think the discussion around linking financial data to, the thinking in terms of investments and how those investments then translate into, measurable outcomes, both on the program or quality side and on the financial side, and bringing those two pieces together is a really exciting opportunity, I think, for us to sort of move the agenda forward in this area, in sort of subsequent phases of the evolution of how we think about this. And, we have been very interested in this area for some time, but, it's somewhat challenging to bring together. But, it would be an exciting area to continue to move into. And I think that, that is it. I really, once again, appreciate Bonnie and Mag and the others from the team who have joined in the review of this area, and look forward to continuing our work together.
Great. Thank you, everyone. Look for some comments on this. So we'll just open it up to the rest of the group at this point.
Just while we're looking at this slide too and awaiting the raised hands, I just want to point out again, I think how fortunate we are in Connecticut to have data extending back to 2015 to 2011, and again, sort of a rich history already in place. I think that is going to be really helpful, especially in this area. And as Mike said, being able to share what we're able to earlier in this process as things evolve.
Ben, I see your hand up.
Yeah, thanks, Brad. And I appreciate Bonnie and Mag. I think you guys brought up this final point around telling the story behind the data, or at least making efforts to do so. And I think I would encourage us to think about doing that, not just for finance and cost related data, but also for quality and well-being and preventive data as well. I think that We discussed earlier some of the potential downfalls of, how sometimes quantitative data, if interpreted in a certain way, can reinforce stigma or stereotypes and so on. And I would encourage us, particularly as we think about how to present this data, to have stories that match some of these more quantitative elements. Of course, you need to do that thoughtfully, right? Because you don't want to essentialize or oversimplify things with a certain story. But I do think that will be helpful in making this data as actionable as possible to the broadest possible audience.
Thank you, Ben. I think point very well taken. Kate.
Yeah, Ben, thank you so much. We heartily concur on that. And I just wanted to refresh everyone's recollection that one existing example of that we're already using is in the Money Follows the Person program. The quarterly dashboard that is produced by the UConn Center on Aging always includes a narrative, which I think is really carefully approached from a standpoint of dignity, self-direction, the stories that originate within the lived experience of a person, rather than us, deciding to, develop a composite or an archetype of a person served. And that's been a very dynamic process, and it's often so joyful. That's an element that I feel like we really need to be attentive to, the impact of the opportunities and the services on people's quality of life, their sense of engagement as members of the community. These are all very purposeful elements of Money Follows the Person in affording folks opportunities to leave institutional settings and to rejoin the community that are commensurately important to us, just as important as the process measures or the outcome measures related to health. So anything that we can think about to incorporate that across populations, would be very much welcome. We're also having a very dynamic discussion of those pieces around lived experience and the maternity bundle work that Fatmata Williams and Brad are leading, along with a very diverse array of stakeholders. So invite folks to weigh in on the means of doing this in terms of elevating that in the dashboard. We'd be really interested in your thoughts.
Thanks, Kate. Susanna, I see your hand up, and then Mag. Susanna, you're still on mute.
How about now? Sorry.
No problem. I can hear you.
I have a question for this group, which is how you think about benchmarks. I mean, now I won't necessarily put benchmarks on the dashboard, I don't know, but it relates to the telling the story, whereas better health has an obvious direction, we want more people more healthy. When we're publicly trying to share information about cost, what do you guys think about in terms of telling the story in terms of what the goals or benchmarks are?
I was just going to speak to that. That's why I raised my hand. So can in a way, I was just going to illustrate that we have a benchmark. For instance, if you were just to look at what's Connecticut spending on community-based long-term care, and you said, my gosh, every year it's going up. Why is it going up? Well, one of our benchmarks is that it go up. Our intention is to be spending more money in the community than in the nursing home. But I think if you don't tell people that that's your benchmark, or tell people, the story behind that line item or that trend, then people misinterpret the data or potentially misinterpret it. So I think it's important to put what our benchmarks are, or what our policy goals are in relation to the spend, so that the person viewing the benchmark has a better understanding, has some context to it.
Mike, would you be willing to touch on that? Because I think the categories of service alignment is, I think, a very, very intentional part of what you've produced so far.
Yeah, thank you, Kate. I was trying to figure out how to raise my hand and was having trouble getting to the right screen. So I appreciate the invite. So specifically to the category service piece, I think in some of our work for MAPOC, we had tried to intentionally look at service categories to determine, to get to that issue. And I think the issue would be, if we're setting out strategic policy or program goals, how are the dollars following those goals? Now, admittedly, it was from a very broad perspective, and there certainly are opportunities, I think, to refine the approach. But I think Mag's earlier point, if our focus is on primary care, are the dollars following our strategic focus in terms of trying to expand, access to primary care and increase the number of primary care providers? Now, we would, of course, measure that from a expenditure perspective or a shift in expenditure perspective. And certainly there are other ways to look at that from a quality or outcome perspective. But, are the pieces aligning? If one of our goals is to move to more community-oriented long-term services and supports, are we seeing a shift in dollars that would be reflective of those policy or strategic aims? So, we do have work to do in this area, but this was part of what we had been trying to do in our MAPOC presentations around some of the category of service detail and, support those kind of comparisons. I think in general, just, maybe stepping back to, that idea of benchmarking, I think the framework for this sort of high level work, public facing work, has always been, somebody from the outside looking at the Medicaid program, what sort of things would they latch onto if they were looking to determine if the Medicaid program were operating efficiently and cost effectively. So from a benchmarking perspective, while we haven't necessarily targeted certain levels of performance, we have tried to put out the information that we thought would be applicable to, one, demonstrating those particular facets of the program, but also to at least provide a framework for people to think about, okay, what is a reasonable benchmark, for measuring PMPM? Is it appropriate to use medical cost inflation as a benchmark? Is it appropriate to use some other payer mix, composite payer mix increase to compare to? So, we've tried to put the information out there without necessarily setting a specific benchmark to demonstrate, where we're at. I think if we're looking to formalize benchmarks, right, that's a different process, but we have the framework to be able to do that, I guess, is where I was headed.
Thank you, Mike. Sandy, I see your hand up. You're still on mute.
Sorry. So what's the definition of clinics in the service category expenditures? So there's clinics and there's physicians, and I didn't know what that different, how you define the differences.
So, Sandy, this is where the data dictionary that Bonnie was describing would be particularly helpful, right? And I think in many cases when we're making these presentations, we would footnote areas where we definitely thought there might be confusion or where definitions need to be clarified, but we certainly miss some of those as we do this. And I think that supporting crosswalk, if you would, of the service categories would be particularly helpful. Here, I would just say that these are primarily, I would say most of this is made up of the FQHCs in terms of a composite of expenditures, but it would also include other clinics, freestanding clinics, if you would, I believe. And I'm not sure if there are others who are more expert in the definition around this area, but those, I believe, are the main categories that would fall under here. But once again, it definitely points out the need for the data dictionary that you spoke to.
I guess it's the way, like, so it would be maybe the way the payment is made. What NPI number is being used, perhaps. I don't know. I just was wondering what or if that was some kind of a different type, like a mental health clinic or something, some other clinic where there's non-physician people.
Mike, this is Bill Halsey. I think,
Hi, Bill.
can you hear me?
Yes.
Sandy, I think your reference to behavioral health, I think behavioral health is definitely in the clinic category. So the traditional behavioral health licensed clinics for adults and children are in that category, as you stated.
Thank you, Bill.
Any other comments, thoughts on this? I'll take this opportunity just to put something out there. I think as we've been talking about the quality metrics, we've been talking about thinking about it for the entire spectrum, even considering public health, very upstream measures. And I wonder if that's something we should be thinking about for cost as well, things outside of Medicaid that we want to try to make sure is displayed, thinking about Betsy Bradley's work and thinking about other social spend, things that may impact health. Do we want to think about, maybe not initially, but as a phased approach, including information on education expenditures, et cetera, as a very upstream cost driver of things that we know impact health and well-being. So just something to put out there. Obviously there's complexity in doing that, but might be something we want to consider in light of what we're thinking about doing for the quality metrics.
And Fred, it's a great point for both understanding from the investment side and also for where we might see potential outcomes and benefits for the ROI. So being able to get to the point where we can be considering the financial information across systems as part of this later would be wonderful.
Thank you, Bonnie. Any other thoughts, questions on this, input? All right, well, I think we can actually go on to discuss next steps. And so just a few things that I put on here, and these are up for some discussion, but I think it would make sense for our subgroups to plan on meeting again and again, kind of as needed. So I know we had some discussion about each of the topic areas. And so it seems that we can, at least maybe principals only needs one meeting, but maybe the quality metrics or the finance need two or more. And I think we can kind of allow each of the subgroups to decide what makes the most sense. Incorporating some of the feedback. And I think the other piece of this is, as we've been discussing, like there's a kind of phased approach to some of these things, and we can start kind of, I think, thinking about what that phased approach is, at least for the quality and the cost, is like, what do we have, kind of as Mike had just said, we have a lot of this stuff that's already being presented at places like MAPOC, it's ready to go on day one. What are things for year 2 or 3 that we want to list out there? And the same with the quality metrics, et cetera. Does that sound like a reasonable next step to everyone? Does anyone have any feedback on that specifically? Karen, please go ahead.
Yeah, I think that sounds like a reasonable next step. I think I have some questions about how process does or doesn't fit into that conversation. So just for example, at the last stakeholder meeting on the maternity bundle, there were a bunch of questions about how the data is going to be disaggregated or stratified and looked at, and what the comparisons are. And there were some comments made about race, ethnicity, and language data not being high enough quality to use for those purposes. So then, in this context, my question would be, okay, well, where is the quality improvement process for collecting that data? Where does that fit into this so that we can ensure that that data can be used in future models?
Thanks, Karen. Any thoughts on that from any other members? I'll just say I think that's an important point. I think something that I know Susan has been thinking a lot about internally as well within DSS, in terms of making sure we have access to those key demographic descriptors so that we know where there are disparities so we can accurately describe that and present that. So I think, Karen, your point is well taken. I'm not certain myself where that fits into this process in terms of but I think your point is very well made, and I don't think it's unreasonable to bring it back to the subgroups for discussion further.
So Brad, if I may kind of jump in a little bit. I've really been kind of thinking about some of the work of this body and the executive order within the broader rubric of what we need to do for the agency. So as I'm listening to the principals, I'm thinking about, how do we incorporate that broadly on, issues of quality. So we have an internal data governance committee that meets monthly, and data quality is one of those things that we're prioritizing. And we've been particularly looking at mapping race and ethnicity and looking to continue to unpack other demographics to get underneath our quality, looking at best practices across the nation in terms of how we can improve that. So there is work going on across the agency. So I'm, again, part of my participation in this is not only obviously to support the recommendations that this body is identifying, but also to think about where do they fit in across the agency or across our enterprise. So the quality of race and ethnicity and other demographics is really top of mind for us. And I'm not looking at it discretely from this process.
Thank you, Susan. And so I think that maybe that'll be a helpful conversation to have in a subgroup, Susan, including the quality one, which I know, Karen, you're on as well. And so that's an important thing to kind of, I think, loop back on in that subgroup. In terms, any other feedback in terms of this as a next process step? I think the finance group already has a scheduled meeting. I'll just ask Jody to help schedule the other 2 subgroup meetings in the meantime. Again, I think the principals one may be briefer may only need 1 versus more for the finance or the quality, but that's completely fine. The next thing, and I know we've been talking about this, and Susan, I know, has already been thinking about this, is mocking up a possible dashboard and what that could look like, just as an example for obviously that would be helpful just to get some feedback. And obviously Susan has a lot on her plate with this committee, with this board. We've been taxing her quite a bit given her expertise and role. And so just wanting to be mindful that may or may not be for our next meeting. Maybe that's actually the subsequent meeting, but and I'm always happy to help as any way I can with that as well. And then starting to think about how we're going to draft our recommendations, and pulling those together. And I think we'll want to start pulling in some of these pieces, including our stated goals, our principles, our decision points, and then make sure we're incorporating all the subgroup work into this as well. I think we will have a very nice, I can already kind of see this coming together really nicely. And so I'm just very thankful, and I know Kate and Susan are as well, to the expertise of the group here to helping kind of pull together this very thoughtful approach to what we're going to be recommending moving forward. And then the last thing is we have our next meeting in about a month or so. And then we have one subsequent meeting, or kind of a final meeting after that. So I do think we're getting close to having this comprehensive package. Sorry about that. Kate or Susan, any other final comments or any other feedback from the board before we wrap up a few minutes early? We'll make sure to give people back hopefully about 15 minutes, which will be ideal. And is a goal that Kate and I have been trying to do as well. So.
Right. No, and I want to hew to that. We are trying to give people transition time. So I think I just say it beautifully said, and we're so grateful to all of you. But Susan, your thoughts?
I'm sorry, I'm having trouble getting myself off mute. no, this has been a wonderful session as always, and I'm very excited to be a part of this. And yeah, I have a lot going on, but again, I'm really thinking about this as integrative of a part of other work that we're looking to do in terms of enterprise dashboarding. So it is my hope that maybe by the next meeting, but certainly by the meeting after that, to have something that at least kind of conceptualizes some of this and starting to really think about, at least at a higher level, some of these really great points and how do we really incorporate that within our web setting, but really what kind of presentations are going to make sense for folks. So again, I learned so much and take so much away. So I thank you all for your time and expertise.
Thanks, Susan. And I just wanted to add one other thing. If someone's not on a subgroup and they'd like to join, you should feel welcome to do so. Feel free to email me. I'm happy to help make sure you get coordinated and looped into those subsequent meetings. So feel free to message me about that. Just shoot it to my email. All right, everyone. Well, this has been great. I appreciate everyone's engagement again. Just really fantastic. I am so thankful to have all of you participate in your expertise, and I look forward to further meetings. So until we meet again, May 25th, we'll make sure to get out kind of a summary that Kate and Susan and I will put together, and then we'll be seeing some of you in the sub meeting. So stop our share. And this is available on YouTube. So if anyone wants to go back and watch it, you can do that. It'll be enjoyable watching, hopefully.